Welcome to the recorded version of Recognizing the Signs of Aging and the Need for Care, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Home Instead Senior Care.
I'd like to introduce our presenters today. Dr. Amy Dupree is the Executive Director of the DAI Foundation, a nonprofit organization established to meet the needs of caregivers. Dr. Amy is also the president of Dr. Amy Inc., a company dedicated to family caregiver wellness by providing access to information and education services, support with emotional and family issues, and legal and financial support. She holds a PhD and master's in social work. Joining us for the Q&A session today is going to be Mary Alexander. Mary is the Director of Business Relationships with Home Instead Senior Care Corporation, and she actively manages strategic partnerships with companies, associations, and organizations whose products, services, and programs help franchise owners grow their businesses. And without any further hesitation, I'd like to turn the presentation over to Dr. Amy Dupree.
Thanks, Steve. I appreciate that. I just want to say I'm on the line, I feel, with a lot of fellow social workers when I see that, as well as other professionals who are working with seniors. I want to tell you a little bit about my background before I launch into the actual presentation. I'm a gerontological social worker, and I began working with seniors and their families over 25 years ago. And I started my career as a home care social worker, where I helped families with the topics we're discussing today, including recognizing the signs that lead to the need for some care. And, of course, how to find that care once you know that you need it. I've had the opportunity to work with many, many caregiving families, as well as countless professionals like you who work with caregiving families. And then I had the opportunity to be a caregiver myself to my own parents, and I had that chance for nearly a decade. My mother had a massive stroke that left her very disabled, and after she rehabbed in a facility for about a year, I was able to get my mother back home, where she lived with my father for nearly 7 years until her death. My mother required a lot of care to remain at home. She was paralyzed on her right side. She was incontinent. She had cognitive issues. She was wheelchair-bound, lost most of her speech. I was so happy we were able to keep her at home with my dad, and we did that with fabulous home care, daycare, and other community services. And then in the last couple of years of my father's life, he also needed some assistance. Now, his need for help was much less intense than my mother's. Still, it was because of the attention to the signs and symptoms that we're going to discuss today and the help of really caring and competent home care workers that my father also remained independent at home until his death. So let's talk about how to recognize when your patient needs some additional care. I told you that my father needed some care in the last couple of years of his life. But it took a while before it became evident that he needed help because the changes were slow. And when I talk to family caregivers, I often talk to them about the fact that there are two major routes by which people become caregivers. One is through what I say is the phone call. You find out that your loved one has had a stroke or a heart attack or a fall. Something rather dramatic has happened that changes functioning very quickly. The second route people become caregivers through is the slow decline route. And I think sometimes the slow decline route is trickier because it takes longer to realize something's happening because the changes occur so slowly over time. In the other route, the phone call route, I often say that if you look at caregiving for an aging family member versus becoming a parent, it's the difference between having 9 months to prepare to become a parent or perhaps 9 minutes to prepare to become a caregiver. So certainly that route's very dramatic. And I got to experience each of these routes, the dramatic route with my mother and the slower route with my father. So it took me a while to pick it up because I wasn't living near my father. I was in a different state, and I was visiting him frequently, but obviously not as much as if we lived in the same town. So on my visits, what happened was I started to see changes, and I know all of you have experienced this with your patients as well. So one time I went and the house seemed unusually dirty. I started to notice things like the kitchen counters were sticky and there were crumbs all over. And then another visit, I noticed that my dad's appearance was starting to change, that he didn't smell as clean as he usually did or look as clean as he usually did. And then one of the key things that I noticed on another visit were a lot more dents in the car, which I'll talk about later. that I started to notice that there were significant dents in the car and new ones every time. My father kept telling me everything was fine, but I could see and feel that it wasn't. Many of you likely have patients or their families who are dealing with very similar situations to what I just described. So during today's webinar, we're going to talk about how to recognize the signs of aging and the need for care, including specifically the three that you see listed there: physical symptoms and emotional changes, loss of attention signals, and environmental clues. My goal today is to provide you with information you need to determine if your patient needs assistance at home, and then share what you can do to support their independence as long as possible, as well as what you can do to support the families of the patients. Now, this presentation was originally designed for a family audience, so many of you are going to be very familiar with a lot of this. However, it's a good refresher and it's good reminders, and the material really does apply to all of us. And one of the things I hope is as you listen to this, that you really think about this in terms of what you can share with families that you're working with on behalf of elderly patients. At the end of the presentation, we're going to have time for some Q&A, and I hope that as we go through this, that you will just jot questions down that you will share at the end of the presentation. Okay, now home. Home is a really loaded word. I love what Dorothy said about home. There's no place like home. And I think that becomes more and more true the older that we get. When you think about the word, it conjures up all kinds of good feelings such as safety and love and warmth and family. We all want to be where we have those good feelings, what's home for us, where we feel most comfortable. So it's no wonder that nearly 90% of seniors say home is where they want to be. There's a lot of good reasons seniors want to stay at home, including, obviously, the desire to remain independent. Actually, we know that the fear of the potential loss of independence is one of the biggest driving factors for seniors who want to stay at home. Probably all of us can relate to that desire to remain independent, and also to the second desire of maintaining the lifestyle we're comfortable and familiar with. It's likely we'll all want to do that right to the end of our lives. And of course, our patients want that too. And then in addition, we know as people age, they have a great concern about avoiding being a burden on their families. So these three things, the desire to remain independent, the desire to maintain current lifestyle, and the desire to avoid being a burden on their families, may lead to seniors denying their true need for care and to possibly making bad decisions about what they really need to do to remain at home. I am sure almost everyone on this call has multiple stories about where you've seen that happen with your patients. And when I think back on a couple of the clients that I worked with where I saw this, it seemed to me that they were related to pets in the home, that people had pets, that they didn't want to leave their home. They were afraid if they acknowledged that they had a need for some help, someone was going to put them in a nursing home. And so they continued to decline at home in the interest of having that social support from the pets. I saw this with one client who had a dog, and this woman had become quite disabled, and she couldn't even take the dog out anymore, so the dog was defecating in the house. And the house was just a mess. And when we came in to talk to her about the need for some help, she denied any need for care. Again, she wanted to remain independent. She didn't want to be a burden, and she didn't know there were any other options besides a nursing home. I remember another couple who had visual issues and had cats, and they had no idea that there were bugs all over the house because of the cat's food. And again, it was an issue of fear that was driving them, their fear that they were going to lose their independence. So I think that as we think about that, it's so key that we're aware that this is driving so many people, and that we also are aware of the signs that help is needed, and aware that ignoring these warning signs will likely lead to the kind of dependence that people are actually trying to avoid. And the truth is, people don't need to be a gerontological expert to determine if someone needs some extra help. So as you're working with patients' families, they really often are your best eyes. I'll actually give you some easily identifiable signs to look for and that fall into one of three categories: physical symptoms and mental emotional changes, The second is loss of attention signals, and the third is environmental clues. And then I'll discuss a number of ways that you can help your patients ensure that they have the assistance they need in order to live safely and comfortably. Let's start with the physical symptoms and the emotional changes. So some of the things obviously to look for is, does your patient seem tired all the time? When you call, are you always waking them from a nap? We know that persistent fatigue and loss of energy are just two of the physical signs that an elderly person may be struggling and may need extra assistance. And family members, again, often aren't as aware of this because sometimes they think that's just part of becoming old. And the truth is there are often signs that need to be checked out. So recognizing the physical and emotional signs of aging doesn't take a lot of time, and some of these you can hear over the phone or the family members can hear over the phone. So when you talk with your patients, ask how they're feeling and if they're still engaged in their usual social activities. That's an area we don't always assess for. Are they still going to church services? Are they still meeting friends for coffee? If you've noticed they've lost interest in socializing or stopped participating in hobbies, that could be a signal of depression. We know that depression and anxiety are major issues for seniors that should not be ignored. It's also possible that there's an underlying physical health issue that's causing them to back away from the things they once enjoyed. Sometimes the signals you get from your patient is very drastic, such as a major change in mood or outlook. For example, if they go from happy to crying in seconds or come across more irritable and grumpy than normal. Don't ignore those signs. In fact, keep an eye out to see if they persist over a stretch of days or weeks. I was recently working with a caregiving family, and the daughter who's caring for her mother who has dementia told me that when she looks back, she realizes that those changes in moods were the first symptoms of dementia issues for her mother. And she said, at the time, I don't know what I would have done, gone to the doctor and said, my mother's being grumpy, my mother's being irritable, she's snapping at me more. She said, I just thought maybe this was part of her getting old. So again, I think we have to teach family members how to keep their eyes out for these kind of issues. I told you about some of the changes I began noticing with my father's house and appearance. In addition, after my mother died, I also started noticing changes in my father's emotional state. He was quite lonely and depressed. He often would cry when we talked on the phone, which was very unusual for him. And when I asked what he was doing during the day, I gathered he was sleeping a lot more. He was starting to isolate himself. He wasn't going out with his friends like he had been doing. I talked to my dad and asked him if he thought he was depressed. Now, I could do that partly because my father had been a counselor and was very familiar with depression. And he said to me, no, he thought he was really just grieving and that he thought he would get better in time. I told him I wanted to keep talking about it because I know it's common for depression in seniors to go undiagnosed or misdiagnosed. We chatted about it frequently, and fortunately in time he was able to resume his social life and his mood improved. However, for many seniors, we know that depression and anxiety often are not addressed and continue long-term, and those are symptoms that really, really should not be ignored. Let's go to the more physical side now because we're talking about the emotional. So on the physical side, really helping family members look for signs about gait and whether someone's having trouble getting up out of chairs, if they're unsteady when they're standing. Are they using items to balance themselves as they walk from room to room? Again, family members aren't always aware that these things become problems because the changes have occurred so slowly, and we really need to educate them on that. Another area to look, besides just difficulty in mobility, is taking a look in the bathroom to see if you can see some signs that things aren't right. For example, taking a look at towel bars or windowsills and shower curtains. If those things are loose and pulling away from the wall, that's obviously a sign that the senior may be using that in order to balance him or herself. Or in the case of the shower curtain, if it's torn. We know that when people start having trouble getting off the toilet, they often develop a several-step process for using one or more of the items like towel bars and windowsills to get them up. That's a definite sign that help is needed and one we need to look for, but also encourage our family members to look for. Other physical symptoms of underlying health issues are a loss of appetite and weight loss. When seniors start telling us they aren't hungry very often, they don't really feel like eating, they've lost their appetite, it's important that we look at those issues. If possible, if you're able to do this and can take a look at their grocery list, obviously that's great. If not, if their family members can do that. If there's more junk food or items that are easy to prepare but don't have any nutritional value, that can be a problem. In either case, whether or not the person isn't eating or just not eating well, they obviously can be putting themselves at risk of lacking proper nutrition. And we know that that leads to more serious health issues and something we really can't ignore in seniors. These physical and emotional signs sometimes are tough for family members to face, but ignoring any of them could prove more dangerous and more costly to your patient in the long run. Now, those aren't the only signs you need to be aware of. Next, I'll talk about loss of attention signals and environmental cues. So let's start with behaviors that signal a loss or lack of attention. Look at your patient's appearance. Looking at how their clothing looks, are they neglecting personal hygiene? We're trained, many of us, to do that, family members or not. If anything seems off, such as a failure to keep up with daily good grooming habits, it obviously can be a sign of depression, dementia, or other health issues. For some people, it's just a sign that their vision is a problem and they can't see the stains on their clothing. If your elderly patient is still driving, this is something we all need to be aware of, the possibility of diminished driving skills. We certainly know many elderly people drive just fine for right up to the end of their lives, but we also all know that a lot of folks have diminished driving skills such as slow response time or rolling through stop signs. Other concerns are missing turns because they can't read the signs or braking quickly to try to avoid rear-ending someone. There's been a lot of media attention, as you know, paid lately to the issues around elderly drivers. And so what we really need to do is be very aware of the issues that could lead to a decline in driving skills, because it's not only a risk, obviously, to your patient's life, it's also that they may be putting the lives of other people in danger as well. I know this is a really tough issue to deal with. I encourage professionals and family members alike to have conversations about potential driving issues. I know how difficult these conversations are because I've had them professionally with many seniors, and I've had the conversation personally with my own father. My father had macular degeneration that significantly impacted his vision, and he had balance and mobility issues that impacted his ability to react and maneuver the car safely. Now, when you're talking to a patient about their driving, and again, this is a formula that I think works well for us to teach to families too, first acknowledge how much driving is related to our sense of independence and how difficult it would be for us if someone told us that we should think about stopping driving. I often start the conversation by saying something like, Mrs. Johnson, I'm guessing you may be like me in this way, in that you may love to drive. And I know since the time I first got my license, driving has been a big part of my independence and freedom, and I can't imagine giving it up. So I hope you'll know this is hard for me to talk to you about because I want you to have your independence and freedom forever. However, I've noticed some things that caused me to become concerned about your safety and the safety of other people. And here's what I've noticed. And this is where we then just talk very directly about our concerns. And then we can wrap it up by saying, I'm wondering if we should start exploring other ways for you to be able to get around easily without your car so that you can maintain your independence and freedom. This approach obviously doesn't always work. It may not work right away, but it can open up the conversation. And it often supports family members who are also expressing their concerns and probably not that clearly. We know that professionals often have an easier time dealing with this one than family members. I know a lot of family members will say they talk to their loved ones and they keep trying to bring this issue up, and the person is very resistant. I actually did find that with my father. I had that situation. My father was not at all open to this conversation. My father had 3 car accidents in the last year he drove, and for those reasons that I mentioned earlier, he lived in a town with a lot of stop signs, and people would roll through the stop signs, and he couldn't see them because of his macular degeneration, and he couldn't get to the brake quickly enough. Now, if you'd ask my father, he would have told you none of those accidents were his fault. They were all 3 somebody else's fault. But obviously, I was quite concerned about this, and I would talk to my father about it regularly. And I'd say to him, Dad, people pay me to actually offer this kind of advice. And he'd say, yes, but you're just my daughter. And actually what helped my father finally stop driving was that a woman he had started dating a couple years after my mother passed encouraged him to consider that there were other ways to get around. She had given up her car a year earlier. And because a peer of his saw this as something that hadn't taken away her freedom, my father became open to it. Now, I will tell you a little ending to this story, which is 6 months after my father stopped driving. I was taking him somewhere, I can't remember, and we were driving along, and my father said to me, I'm thinking I'm going to start driving again. I'm going to get my license and drive again. And, of course, because I'm a well-trained professional, I knew exactly how to react to this. So I turned to my father and I said, "You've got to be kidding me," to which you can imagine he did not handle that very well. I recovered quickly, is the good news, and said to my dad, "I'm sorry, that was not very sensitive. I'm sure this is a horrible situation," and I immediately went into empathy mode. But it was such a good experience for me because it gave me better appreciation for what family members go through in their fear and their concern for their loved ones. So I think we have to remember that that's where they're coming from, and it's harder for them to go into this place of just empathy. Okay, so other signs you can look for beyond the driving that demonstrate difficulty concentrating or memory loss. Somebody who loved to read and now they seem to have a lack of interest in it, or they're missing appointments or mishandling medications. Is that an issue of vision? Is it an issue of cognitive? Those are serious concerns that we and family members need to be addressing. Carefully examining prescription bottles, checking the refill date against the number of pills in the bottle, and determining if the patient's taking the medication regularly and also at the times they're supposed to be. You can also call the pharmacy to check the status of timely refills. Memory loss, forgetfulness, and confusion often reveal themselves through things like missed doctor's appointments or calling you at odd hours or asking you odd questions and placing things, obviously, in the house in place that doesn't make sense. We often say it's not when you can't find your keys that's an issue. But if you open your freezer and you're finding your keys in the freezer on a regular basis, that's probably an issue. That's not where we expect to see keys. Poor judgment can also come in the form of deciding against going to a doctor because they said, well, I just went last week, even though it was a different doctor for a different health reason. Certainly, any or all of these signs can cause frustration and concern, but we can reassure family members there are ways to cope and to get help. Before we discuss the ways to take action, let's talk about one last place to look for clues, and that's in the patient's living environment. If you're in a position where you get to go visit your elderly patient's home, it's obviously one of the best places to do assessment, to take a really close look around. Poor housekeeping and lack of home maintenance may be signs that something really isn't right. Specifically, I always suggest people look in the refrigerator and the freezer, and then taking a look at, has food spoiled? Is it because they aren't eating, or is there nothing in there because they can't get to the grocery store? And again, if it's really messy, that could be having a sign of having difficulty cleaning tight, cluttered places. Check the top of furniture and countertops. If you notice dishes piling up in the sink or a lot of dust and dirt, it may be that it's just getting too difficult for them and these tasks are going undone. Or obviously it could be vision issues that are causing them to miss seeing the dust and the dirt, and either cause of that is something that we want to address. Besides looking at what's eye level, take a close look both up and down, looking at ceiling fans, looking at ceilings themselves. Often people develop, as you know, an inability to lift their arms and climb stools, and so they're only able to clean in the little range that they can reach. So soon we start seeing soot and grime all over high places. Look down at floors and stairways. Have shaky hands spilled drinks and food? Do you notice that the carpeting and the walkways are very dirty? Are there frayed carpets, throw rugs? Obviously, all the tripping hazards that we look for, like furniture that's in the way or some sort of decorative things that are sitting in the way that cause tripping hazards. We also suggest you look under beds and sofas, and that's looking really for new clutter. As you know, a lot of folks have issues around getting rid of things, potentially hoarding, and they may just have difficulty organizing old newspapers, books, and magazines, and all of that can create a fire hazard. Lastly, talk to them about their paperwork. Are bills being paid? Are they answering their correspondence? If not, that can be a sign of something serious. All of these environmental clues point to the fact that something needs to be done to help your elderly patient remain independent. So what can you do? What can their family members do? And how can you help encourage the first step? Let's take a look at that. So you've determined, let's say, that your elderly patient may need some assistance and that you may need work with their families, if they have families, to help them take action. Obviously, the first step to ensure this is to share your concerns. And to do that, we really need to talk openly and honestly. If appropriate, think about whether including others who care about them in the conversation will help. I think this step of communication is one of the most important things because we know how we communicate with seniors and their family is key. One of the things that we know as people age is they begin to feel that no one listens to them. I think the number one human need is to feel heard and understood. Not agreed with, but just heard and understood. And if we were to go talk to seniors, whether they are patients or not, I think what you will hear over and over is they don't feel they get that consideration. They don't feel heard. A lot of times their family members have trouble hearing them because of their own anxieties and fears. And we as professionals get busy and we start to need to move things along. And sometimes it's hard to step back and deal with the emotion that's involved in a lot of what we're talking about. The result is seniors feel pushed. They feel unheard. And again, one doesn't have to be sick to have this happen or to be frail to have this happen. I had this conversation recently this week with a friend of mine who was with her mother who's 83 years old, and she told me how she's noticed in the last year when she goes with her mother to stores that no one talks to her mother, they talk to her. Her mother's in the process of selling her house and moving, and all of the professionals who are dealing with her mother, who is completely competent, makes her own decisions, and is managing all this move, all of these professionals immediately look to the daughter if the daughter's in the room. And the mother has said she's very frustrated by this. I think we all need to acknowledge that still in our society, age creates invisibility. And we need to help reverse that and teach others how to reverse that. We certainly want to do it because it's the right thing to do professionally, and selfishly we want to do it because we'd like to change society so as we age, we don't fall into this invisibility. So there's good reasons to do it either way. So I think, again, open, direct communication from the perspective of the senior that shows empathy is so key. You might even want to have prepared notes or a list of your concerns that you can then leave with the senior, leave with their family members if appropriate, so that they can think about it. They have time to adjust to, okay, these are the concerns of somebody who is a professional who knows better than I do, and perhaps that will motivate them to get the appropriate help. After communicating the concerns, obviously encourage a medical checkup. If you notice a lot of the physical warning signs, such as weight loss or depressed mood, encourage your patient to schedule a doctor visit. Depending on the situation, you might want to offer to make the call or accompany them to the doctor. It's also important for you to ask about follow-up visits and medications and therapies, and when appropriate to, and the patient is willing, to have their family members also be aware of those things. Perhaps you found signs about safety issues or that's your bigger concern. That's really a two-prong approach of first pointing out the safety issues and then making a plan to address them. You know, we all know that some of these changes are quite simple, like better lighting and removing rugs or installing grab bars in the home or handrails on the outside step, but those things do need to be addressed. And if the person is not capable of driving anymore or is having trouble taking care of personal grooming or can't get to the store, we really need to consider home care services. We know that these wonderful people do everything from cleaning the house to preparing meals to running errands and assisting with daily activities such as bathing and dressing. And in addition, they offer a lot of social support that many of our elderly patients need. I know because I've been working in some capacity. I told you I started my career as a home care social worker, and then I had home care for both of my own parents. I can't say enough about what a lifesaver I think those services are to help people stay independent and to feel in control of their lives. Another community service that you might want to consider is Meals on Wheels. We all know they offer assistance with regular nutritional meals, really key. And speaking of community services, don't forget your local agency or council on aging. They can be a great resource for help and information, and many of them offer both assessment services and assistance to help families sign up for needed care. In the end, if your elderly patient dismisses your concerns, the steps you may just need to take is to contact your doctor for guidance. Finally, you may, over and over, as we know, need to remind people that we're acting out of concern and care, and that our goal is to help them remain as independent as possible. I really don't think we can say that to people enough, because their fear is so great, they often have a hard time hearing all the good things that are happening. And don't forget about your elderly patient's family. I believe one of the best ways for family caregivers to ease their burden is to partner with professional service providers, such as home care and community services, to ensure that their loved ones get the best care possible. It's really important that we help reinforce the message for family caregivers that the goal is not that they provide all the services to their loved ones. It is to make sure their loved one gets the best care possible. I found when I went through this that the social workers I dealt with, the folks in the various places where my mother especially was receiving help, often didn't talk to me about services. They then instead assumed that the family was going to do everything. And I think as professionals, we really need to be the ones encouraging families to partner with the formal care system in order to provide the best care possible for their family members. We know that partnering with home and community services often helps families, caregivers, prevent burnout so they can be there for their loved one for the long haul. Again, this happened just this week. I talked with a caregiver, Janine, and she was trying to provide all the care for her mom while she was working and taking care of her kids. And I suggested to her that she think about hiring some home care to provide some of the help. And she told me that she was resistant to that because she thought she should do it. And I told her what other caregivers have told me when they have done this, which is that what it has done for them is it allowed them to spend more time with their aging parent just being the daughter or just being the son and not just running around doing tasks. And then a lot of times it really improves the quality of the relationship. It doesn't get in the way of it. It just allows the daughter to be the daughter or the son to be the son or the spouse to be the spouse. So again, I think people have an image in their head that they failed their relative if they have hired services instead of seeing it as a way for everyone to thrive, the senior to have even better care, and for the caregiver to be able to go the long run. Now, I mentioned community services, and they're up there just so that you can see them. So I just wanted to make sure everybody's aware of those. Okay, so as we wrap up the presentation, I hope there were things in this that you found helpful, encouraging, reminders. For most of you, this is a review session, but I think the reminders I hope you take away with are not so much even what you're going to do, but how you're going to support family caregivers as they go through this journey. I think it's easy for those of us who've worked in the fields for a long time to forget that for people who become caregivers, this is all brand new, and they don't know the signs and symptoms. They don't know where to find the help. They don't know how to do this. So we've gone over a fair amount of information. What I'd like you to do is just think about perhaps what the next steps are for you. How can you take action to work with patients' families better to help them get this information? How can you do perhaps even a better job of teaching them how to have the conversations around stopping driving or the need for care? And how can you support that? Because I think the more we see ourselves as partners with the family, the better we can do by our elderly patients as well. And I just want to thank you for joining the webinar today. We're going to move to questions and answers right now, I believe.
Great. Thanks very much, Dr. Amy. Very informative presentation. A lot of good information. Joining us for the Q&A session right now is going to be Mary Alexander, who is the Director of Business Relationships with Home Instead Senior Care Corporation. So Dr. Amy and Mary, thanks for joining us today, and let's jump right into the Q&A session. Dr. Amy, is there a fear of nursing homes, and how do we address that fear?
Well, I think there is a fear of nursing homes for many people, and I think there are a lot of ways we can address the fears. First of all, as all of us know, there are certainly wonderful nursing homes, so this is not that all nursing homes are bad, but that's the image people often have in their mind. I also think a lot of folks think if they go into a nursing home that it means they can never come back home, and that's really not true. Both of my parents at various times, my mother when she was rehabbing and my father when he was rehabbing, spent a period of time in a nursing home, and then we were able to get them back home with home care. So it doesn't have to be I think a lot of folks think if I go in, it's forever. And then I think sometimes people just don't know that there are options to nursing homes. So understanding the whole continuum of care and educating families that there's a lot available from community services, home care, residential care, and letting them make informed choices. And again, remember that fact, 90% of people said that they would like to stay at home.
Okay, great. Thanks for the information. Another question for you. I work in a hospital setting, and I feel the pressure from our administrator to reduce unnecessary hospital readmissions for seniors. How can home care play a part in that?
Well, this is Mary, and let me answer that question for you, Steve, or for whoever asked it. Home Instead Senior Care has been researching this topic with a number of experts for over 16 months. And I want to give you just a balcony view of what we found. We know that Medicare is creating a penalty process for hospitals that have to do with unnecessary hospital readmissions. We also know that traditional health plans are looking at ways to reduce unnecessary hospital readmissions to lower their costs. And the discharge process is really the area that everyone seems to be focusing on. And I know that that affects most of you on this call. So in our research, what we found is there are four main areas which we call the four pillars. The first pillar is really about the care plan. It's that the client or the patient and their family members clearly understand the care plan and all the elements associated with it. The second pillar is medication management, which I'm sure most of you hear on a regular basis. The third pillar is follow-up visits. It's getting that patient to the right doctors at the right time, depending on what their care plan says. It's also making sure that they hit their OT and their PT appointments as well. And then the last pillar is the warning signs. It's heading off a crisis before it happens. If you have a patient that's diabetic, it's knowing when the level goes above X or below Y, what do you do in that situation so that it doesn't have to be another hospital readmission. Currently, we're piloting how home care services can work in the hospital setting upon discharge, and we're seeing some amazing results in the reduction of unnecessary hospital readmissions. So again, I think that this is an area that's only going to become more complex, and it seems like all the payer sources are really looking at the hospital readmission issue.
Okay, we have another question here. You were talking earlier about aging at home, but there's a lot of confusion about home care and home health care. How do you explain the difference to your clients and their family members?
Another great question. You know, we are asked all the time by our patients and clients to give us a better explanation about home care versus home health care. And the way that we define it is home care is performed by a trained caregiver and assists with ADLs, which are eating, dressing, bathing, continence, toileting, and transferring, and then the IADLs. It's preparing the meals and all of those other activities to keep a senior safe and thriving in their home. But what we found, too, is socialization is critical to keeping that senior safe and thriving in their home as well. And we describe home health care this way. It's performed by a trained medical professional and assists with needs such as wound care. and maybe inserting feeding tubes or administering morphine in a hospice situation. But sometimes the patient needs both types of services. Normally a greater number of hours for home care and just a few hours of the home health care. And so we tend to work together with those agencies to make sure the client has all the needs in the home to keep them safe and secure. We've also created a guide. It's called the Home Care Solutions Guide because this question is being asked a lot. And again, at the end of the presentation, we'll give you some web addresses, but at homeinstead.com or caregiverstress.com, under the resource section, you can download a copy of the Home Care Guide if one of your clients or patients or family members need the guide.
Okay, many of the questions that we are receiving are kind of echoing the same theme, and that theme is older adults who are displaying some or all of the symptoms that have been discussed, but they will not accept any services or any help. How do you deal with addressing that resistance?
Yeah, resistance is a huge issue, and I think, one of the things that we always have a responsibility to look at is safety first. So and here's the big differentiator, if a person appears to be cognitively intact, people have a right to make what we think are bad decisions if they are cognitively intact. If somebody, we have real concerns about their cognitive functioning, that needs to be addressed first and foremost. So ultimately, if nothing else can happen and you're really in a bind, we all have at our disposal the ability to call Adult Protective Services if we're really concerned about the safety of someone. So I think we have to always go back to safety and then the cognitive intact versus not being cognitively intact. Okay, so let's move beyond that, and now it's just pure resistance, right? So now we're talking about someone who doesn't want any sort of help. I think a lot of the times part of the issue is that no one has gotten into what is the person's concern. What is their real deep concern? Are they afraid they're going to lose their independence? Because if that's an issue, that needs to be addressed about ways to keep their independence. I think people are really genuinely afraid a lot of times that they are going to be just taken away and put in a nursing home. And we're not in that position, so we don't understand that fear. The other thing I think we have to recognize is there are people who have been difficult their entire lives that continue to be difficult late into their senior years. Not everybody is easy to deal with, and certainly we all know families that are struggling with a difficult senior who just does not cooperate with trying to even make sure that they're safe. So a lot of times I think this is about really good assessment to make sure that the safety issues being dealt with, the cognitive issues being dealt with, and then attempting to get at what's the real issue for the senior? What is keeping them from wanting the help? What are their fears? Sometimes it's a fear that it's going to be so expensive they can't afford it. And I think that's where we need to make sure we hear the fear and address the fear with really good practical information, and that we support family members as they're trying to manage this, because I think it's often a very hard situation. And we as professionals, again, sometimes have the ability to get people to see things differently easier than family members do, because family members have so much emotion involved in it. I'm a big advocate of, when possible, getting family members together to talk about things. Doesn't always work. You can't always get every family member. But within the practical aspect of that and helping people work together on behalf of the senior, I think is really key, too. And the final thing I would say, Steve, is there's no silver bullet to this. It's really working through a process. Okay, what's the safety issue? What's the cognitive? What are the resistance issues? Can we address those? What's the person's history around this, around being difficult? And I am sure everyone on the phone, we could spend days never hanging up talking about difficult situations we've had where people really were just incredibly resistant. And some things work and some things don't.
Okay, thanks, Dr. Amy. Another question. What do you do if you live far away from your older parents who are showing some of these signs? How do you address that?
That's a really, really good question. I think Mary, do you want to address that?
I can. I'm currently a long-distance caregiver for my dad, and I think the most challenging thing is I don't have eyes there on a constant basis, and so I really have to listen when I'm talking to him on the phone to hear things, to address the challenges that I might not be able to see but I'm feeling. Because the reality is, I have children, I have a career, and I don't get to Arizona very often. And so, again, it's really about the things that you don't see but you can hear. And you need to find someone in the community that maybe can drop in, a friend that you have, an agency of sort that can go in and assess the situation, even if it's just a quick drop by. Amy, do you have anything to add?
I do, and I think what Mary said is just perfect. And I would add to that I also was a long-distance caregiver. And this isn't about spying on our loved ones, but it is about making sure that you do have eyes and ears where you can't be. And I think that what Mary said is key about that. What I found, I was fortunate in one sense because for most of the time I was a caregiver, there were home care workers in and out of the house quite a bit. And so I got to know them. I got to know, who was the provider agency, and I let them know how concerned in the sense that I was involved and interested. And I chatted with them. They had my contact information. And numerous times I got calls from either the home care worker or the agency just to inform me about something that they wondered if I knew about because I wasn't there. And that was very helpful. In addition, my parents were in a community where I knew many of the people that were in their lives. And again, I let people know I was interested, I was concerned, that if they saw things that I could, in any way impact, they please let me know. And again, I got phone calls in that way. I think it is just what Mary said. You have to have some eyes and ears there, not as a way of spying, but as a way of being able to be what you can't be, which is there on a regular basis.
Okay, great. Thanks for that informative answer. Another question for you here. How do you address someone who is having falls at home? The falls are not serious enough to go to the ER, but they are still cause for concern. How would you address that?
That's a great question. I think, again, assessment, a lot of this comes down to understanding what's causing the falls. That makes me have all sorts of questions. Are the falls being caused by medication interactions? Are the falls being caused because the person has lost strength? Is it that their vision isn't good and they're tripping over things? I think all of that needs to be looked at because falls are a serious issue, right? We know that. We know that falls lead to a lot of other problems. And so we have to understand better what might be causing the falls. So first thing I would start with is assessment, because you don't want to wait for this to become a situation where the person is going to the emergency room. You want to catch it ahead of that time and try to prevent that. So I think I would be doing some really good assessment about the etiology of the falls.
Okay. Next question. What about a situation where families don't want to be involved or they have family members that are actually causing problems? How do you handle that for a client?
Steve, I'll answer that, the first part of that, and I'll turn it over to Amy. My family dynamic was such that there were 4 of us siblings trying to deal with both my mother and my father, and it raised a lot of uncomfortable discussions with us. I think we all kind of fell into our birth order. One wanted to take charge, and one didn't want to do anything, and so there was a lot of rivalry around that. And one of the social workers that was helping us with the case gave us some amazing advice, and the advice was this: you each have a role to play, and there are so many elements with your parents' care that need to be taken care of, as well as their finances and their home and so many other elements, that each of you take a role, and then you let the other know what's going on. And that was probably our saving grace, because we all wanted to be involved, but we all wanted to make all of the decisions, and that just simply can't happen. And so, again, finding the best roles that fit each sibling is key. Now, if you don't have siblings and you're going at this alone, you have to find community support. It can be your local church. It can be the local office on aging. It could be, friends or neighbors, but you have to have a support system because you can't do it all on your own. And again, you'll run into resistance with that. You just need to find your core group of people that can maneuver through this new journey.
That was a great answer. And Steve, I just want to add to that. We could spend days talking about this issue, and we actually are going to do a webinar on this issue in the future because I've never worked with a family where this issue didn't come up, either that the person had no kids, they had, family members that did not want to be involved, family members that were causing trouble. What we see come out of the caregiving situation are a lot of family issues that can be avoided. And if they weren't avoided, they can be worked through. And so we're actually going to address that fully in a seminar, which I think just it needs more time than we can give it right now. But Mary's answer was fabulous.
Okay, we've got time for one or two more quick questions. Dr. Amy, you were talking earlier about driving. Whose responsibility is it when an older adult refuses to give up their driver's license?
This is a very hard question to answer. We don't have good answers on this, honestly. We don't have it clear-cut. That it varies a bit state by state on how this works. I think the big issue, again, is safety here, and if you think there's a safety issue, I think as professionals around driving, we just can't ignore those things. We have to continue to push through, whether it's encouraging. If the person's very resistant, obviously we have to respect all the privacy issues. That's key. But if you can get sometimes a doctor involved, the doctor is often the one that has the clout with someone that they will recognize that it's a dangerous situation. I think you have to use all the resources available to you because there is no one person who is solely responsible for this. We don't have a clear-cut system in most states for how to deal with this. It's very difficult. And I think, by the way, just as an aside, I believe that will change over time, but we can't wait for that to change. We have to deal with where people are now.
Okay, I think we've got time for one more quick question. What if a client does not qualify for in-home support but can't afford home health agencies? What do we do in that case?
I'm not exactly sure what so if they don't qualify for any Medicaid waiver programs or any veterans programs, is that what you're saying?
Yes.
They do qualify under Medicare for home health?
Yes.
Well, I think the problem there is that you normally get limited hours on the home health side, especially under the Medicare umbrella. And so you really need to check your state because it varies by state. Some states have a Medicare plan. Some have a PACE program. Some have, other community-based services. And so, there's not a cut and dry answer to that. But I would say what you'll see sometimes is a client will qualify under the Medicare home health need category, and then family members or the client themselves might supplement some home care hours to that because they need more than just a few hours they'll get under home health.
Okay. I see it is just about time for us to wrap up today's presentation. Free CEUs are made possible through a generous contribution from Home Instead Senior Care. You will be receiving a follow-up email with instructions on how to claim those CEUs, so please look out for that. I want to extend a hearty thank you to everybody who joined us today, as well as our two presenters, Dr. Amy Dupree and Mary Alexander. Amy and Mary, thank you so much for your work on this presentation and for joining us today.